Welcome to ACE Inhibitors Made Easy, brought to you by Nurse Muse and Catherine Prado-Lefkowitz. As always, please check out www.nursemuse.com and sign up for that service. It's a great service. It helps you write care plans, and it has a ton of great resources for you as nursing students. So let's jump in and learn about ACE inhibitors. So how do ACE inhibitors work? ACE inhibitors work by interfering the body's renin, angiotensin, aldosterone system from occurring. Now, the goal of RAS, when the body starts producing RAS, it's usually started from the kidneys, and it's because the kidneys are not getting enough blood flow, and so they want to do everything in their power to get more blood to them. Remember that the kidneys are very selfish, and they like their blood first. So the whole purpose of the RAS system is to produce angiotensin II, because angiotensin II is going to contract the muscles surrounding the blood vessels. We're going to narrow the blood vessels. We're going to vasoconstrict them, and we're going to increase our blood pressure because the kidneys want more and more blood. When we activate RAS, we're also going to stimulate the release of aldosterone. And when aldosterone is stimulated, it really keeps the water and sodium inside the body because the body is trying to increase its blood volume and trying to increase its blood pressure. So the whole purpose of the RAS system, the renin-angiotensin-aldosterone system, is to get to angiotensin II and to produce aldosterone. So when the body has angiotensin II floating around it, what's going to happen? Well, the arterioles are going to vasoconstrict. The kidneys are going to keep the water and sodium inside the body, and our adrenal cortex is going to release aldosterone. So when we talk about the renin-angiotensin-aldosterone system, you just need to think it's made up of three hormones. So we have renin, angiotensin II, and aldosterone. So when those kidneys are saying, hey, where's our blood flow? The first stage of RAS is to release renin. And renin is released when there is reduced perfusion going to the kidneys. So again, there's not enough blood getting to the kidneys. The kidneys want more blood. They say we need more blood, and we're going to do this by increasing our blood pressure and increasing our blood volume so we get more blood to us. So next, we have angiotensin I. It's produced in the body. And again, our goal is to get to angiotensin II. So angiotensin I is converted to angiotensin II by the angiotensin converting enzyme, aka ACE. This conversion occurs mainly in the lungs, where ACE is actually produced. So angiotensin converting enzyme converts angiotensin I to angiotensin II, which we do not want to happen. So when we have angiotensin II in our body, what are the cardiac effects? Well, we're going to increase total peripheral resistance. So we're going to vasoconstrict, and we're going to increase our blood pressure. When angiotensin II is floating around the body, of course, it's going to act on the kidneys, and it's going to say, okay, we're going to increase our blood pressure and keep the blood volume up. So we're going to vasoconstrict and also constrict our arteries, and we're going to keep water and sodium in the body so we get more blood volume. And then finally, angiotensin II, it works on the adrenal cortex, and it says, hey, we need more aldosterone. So increasing the levels of aldosterone causes potassium to be excreted, and of course, we're going to keep water and sodium. So we're going to be excreting potassium through the kidneys. We're going to have a lower potassium in our blood values. Okay, ACE also breaks down bradykinin. So bradykinin is a vasodilator. So it relaxes the smooth muscles and increases blood flow. So ACE inhibitors, which are they're used to lower the blood pressure and increase bradykinin. So by giving an ACE inhibitor, because we're not allowing that conversion of angiotensin I to angiotensin II, we're also not allowing the breakdown of bradykinin. So giving an ACE inhibitor actually allows vasodilation. Now, bradykinin has some negative effects for people taking ACE inhibitors. One of the most common effects is producing a dry cough. So the reason for this is that bradykinin, it causes an accumulation of the inflammatory compounds bradykinin and substance P, which are stimulated by the ACE inhibitor. So we're actually increasing bradykinin and substance P in the respiratory tract, in the lungs. So the side effect is a persistent dry cough. This cough is very annoying to some people. It's not harmful, it's just very annoying. So people actually sometimes go to their provider and get placed on a different class of medication. So the organs that are affected when we give an ACE inhibitor are the kidneys, the blood vessels, the heart, brain, and adrenal glands. So when we give an ACE inhibitor, we do not allow angiotensin 1 to convert to angiotensin 2. Our goal is that we're going to increase urine and water and sodium excretion. We're going to reduce resistance in the kidney blood vessels. We're going to increase venous capacity, and we're going to decrease the workload on the heart. So anytime you see a medication ending in PRIL, P-R-I-L, it should alert you that this is an ACE inhibitor. So remember, ACE is the angiotensin converting enzyme. So an ACE inhibitor inhibits the angiotensin converting enzyme to convert angiotensin 1 to angiotensin 2. Remember, when the kidneys feel like they don't have enough blood flow, they're going to activate the RAS system. And the whole goal in activating the RAS system is to produce angiotensin 2 because it's a vasoconstrictor. So we want to constrict those arteries and veins. We want to keep the sodium in water to increase our blood volume. So that's the whole goal of activating the RAS system. When we give an ACE inhibitor, we want to stop this from occurring. So we do not allow the conversion of angiotensin 1 to angiotensin 2. So if we think about what angiotensin 2 does and we don't allow that to happen, our results are going to be having a lower blood pressure, decreasing total peripheral resistance. We're going to get rid of the sodium in the water, and we're going to keep potassium in the blood. So the desired effect of ACE inhibitors is to relax the blood vessels, allow more blood to go through, and decrease that risk of peripheral constriction that the kidneys want because they feel like they're not getting enough blood. So remember, from A&P, you need to remember what preload and afterload is. So preload is volume and afterload is pressure. So preload is the volume of ventricles at the end of systole. So remember, or diastole. So remember, when diastole, during diastole is when our ventricles fill. So we want to look at the volume of blood in the ventricles after they've filled. And then afterload is the pressure that needs to open the aortic valve to eject the blood from the ventricle. So afterload is a pressure, preload is a volume, and ACE inhibitors work on afterload. So who benefits? Who would benefit from taking an ACE inhibitor? They're great for people with fluid overload because, remember, they get rid of water and sodium in the body. It's going to lower the blood pressure because we're not allowing angiotensin 2 to come out in the body and vasoconstrict. ACE inhibitors also decrease preload, and they decrease afterload. So it makes it a lot easier for the heart to pump the blood forward. Remember, people in CHF, their blood likes to back up. This is great to relax the myocardium, allow it to fill up more effectively and more efficiently, and allow it to pump blood forward. So when you're assessing patients who are on ACE inhibitors, we always need to monitor their blood pressure and pulse because we're giving a medication that's going to decrease their blood pressure. So they have a risk of hypotension. We need to make sure if the patient is on another medication that might decrease their blood pressure or pulse, such as diuretics, that we really monitor them closely. Now remember, giving an ACE inhibitor is going to keep potassium in the body. So we need to monitor potassium levels for hyperkalemia. And remember, potassium normal ranges are 3.5 to 5. And remember that they show as tall T waves, peaked T waves on the EKG. Of course, we want to assess the renal function. We want to look at the BUN and creatinine because we are affecting sodium and water excretion in the lungs. And then we need to make sure that our lungs are working appropriately. So our golden standard is that we have at least 30 cc's per hour of urine that we're measuring. Now, one side effect with ACE inhibitors that you need to be aware of is angioedema. And angioedema is like a really deep swelling. It's the swelling of the dermis and the subcutaneous tissues, so it's a deep swelling. And why we worry about angioedema is because it most commonly affects the tongue and the face, and anytime we have swelling of the tongue or the face, it can affect the airway. So we need to be very cognizant of making sure our patient does not have any angioedema signs or symptoms. This occurs mostly in African American patients. And when you're doing your assessment on the patients, we have that dry cough that is a normal side effect, common side effect of ACE inhibitors. When we're doing our assessments, we need to see if the patient is coughing. If the patient is coughing, make sure that it's a side effect of the medication and not an exacerbation of CHF or congestive heart failure. And then one assessment that we need to really make sure of, if we're suspecting that the patient is having an exacerbation of CHF, of course, we need to assess for fluid overload. So we're going to listen to the lungs. We're going to be listening for any crackles. We're going to be watching for any shortness of breath upon exertion. We're going to be looking for any swelling in the extremities. So with the dry hacking cough, you should not see any of these signs. But if your patient is complaining of coughing, they're on an ACE inhibitor, they have a history of CHF, you need to really be ruling out an exacerbation of CHF. Now, side effects of ACE inhibitors that you need to be aware of. So we have the persistent dry hacking cough, as we've talked about. Of course, we need to worry about orthostatic hypotension, because this is a blood pressuring lowering medication. So they might get dizzy if they change positions. So we need to teach them about this. We need to teach them about monitoring their own blood pressure to make sure that they're not becoming hypotensive. And remember that this increases the potassium in the body. It keeps the potassium in the body, so we need to be aware if the patients are taking any other medications that actually keep the potassium in the body as well. Educate them about eating a low potassium diet so that we don't become hyperkalemic. And then we want to worry about the signs and symptoms of angioedema that we talked about. So our patients are going to check their blood pressure and pulse regularly. They're going to avoid salt substitutes. And like I said, we don't want to add more potassium into their body via diet. So talk to them about this. Again, like I said, if they're taking any medications that already keep potassium in the body, we need to be aware of this so that we don't, so our patient doesn't have too much potassium in the body. The dry cough, they can talk to the provider if it's so annoying that they can't live with it. Like I said, it's not critical. It's not going to cause any negative outcomes. And the doctor can change the patient to a different type of medication. We're not going to stop the ACE inhibitor abruptly because it can produce rebound hypertension. We need to educate the patients about signs and symptoms of angioedema, any swelling around their face, lips, or tongue, which can interfere with their respirations, their respiratory tract. And if they miss a dose and they remember it that day, they can go ahead and take that dose of medication. But if they completely miss the day and they remember 2 days later, they should only take the dose prescribed for that day. We do not want them to double up because of the risk of hypotension and dizziness and falling. So that's a safety issue. So I hope this review was helpful. Remember, ACE inhibitors trying to get to angiotensin II. We are not going to allow that to happen. So I hope that you found this helpful. Again, you can always email me, cprado@aol.com, or text me at my number here, and check out Nurse Muse. It's a great tool. All right, I'll see you in the next presentation. Thank you.